Another enormous pleasure on my part to introduce to you Professor Jackie Andrade. Jackie and I, we were talking last night, and I think we first met in Rotterdam in about 1995 at a Memory and Awareness in Anaesthesia International Conference. Jackie was first of all at the MRC unit in Cambridge and then went to Sheffield, and we had some interactions when Jackie was in Sheffield, and then she was appointed as Professor of Cognitive Psychology at Plymouth University, which is where she is now. And I'm really grateful that she's going to tell us all about implicit and explicit memory in relation to anaesthetic awareness. Thank you.
Thank you, Michael, and thanks everybody for coming. What I'm going to do is touch on some of the ground that Ian covered and that Jaydeep covered, so apologies if you recognise some little bits of this, but I'm going to put it all into the context of memory and how, through understanding memory, we can find out a bit more about not only what patients experience and what they don't experience, but also things we can do to improve the anaesthetic experience for them. So I'm going to start with my pet hate phrase, because when I started this work back in the 1990s, every time I gave a talk to an anaesthetist, somebody would come up to me afterwards and say, of course, I've got really good clinical skills, so I know my patients aren't aware because they'd tell me if they were, because I'm such a nice person. Fortunately, nobody says that anymore, so I feel like the field has moved on. But this obviously involves a lot of assumptions about the relationship between memory and consciousness, memory and awareness. It assumes that being conscious of something leaves a memory. That's not true. Ian's shown you some examples of how that isn't true. I'm going to show you some more detailed examples. I'm also going to look at the issue of whether we can have memory without consciousness, because that might have an impact on patients. And I'm going to end up by arguing that what we are conscious of and what we think of what we're conscious of is actually the critical factor. So I'm going to talk about three sorts of memory, starting with explicit memory, as in voluntary recall. You know, being able to say what the capital of France is, being able to say what you ate for breakfast, or recognising things as having been experienced before, so recognising a friend's face. And then I'm going to talk about implicit memory, which is sort of memory that alters our behaviour as a result of some experience, but which we can't voluntarily recall and don't have any sense that it's an experience of remembering. And I'm going to finish up by talking about type of explicit memory associated with trauma, where rather than being able to bring it to mind at will, the memories tend to come unbidden, and that can be very distressing. So to start off with, trying to persuade you even more strongly that not all awareness is remembered. Even light sedation can prevent memory on recovery. So this slide is from a study that we published in 1994, where volunteers who were largely trainee anaesthetists were given different doses of isoflurane, either 0.2% or, in this graph shows data from when they were receiving 0.4% isoflurane, and also some neural stimulation via the nerve stimulator to mimic the sort of stimulation patients might experience during surgery. And there are reasons to think that should promote memory independently of awareness. The orange bar shows you people's abilities while they were sedated with isoflurane to respond by raising their right thumb every time they heard an example of a fruit or whatever category they were given. So they'd hear a list of words like dog, chair, apple, and they'd have to respond to apple. And they were getting just over 60% of those correct. On On recovery, when we gave them a memory test, a recognition test, so it was quite a easy sort of explicit memory test, they were unable to remember hearing any of those words. Now, you might think that, well, maybe it's because they were volunteers and nothing terrible was happening to them. They just weren't bothered about doing the test. You know, they were feeling a bit drowsy and they didn't want to cooperate. We did a similar thing with patients who were sedated with propofol before surgery, where they were going to have a larger dose of propofol for their operation. And if we played words to them before they received any propofol and tested their memory when they came round from the anaesthetic after surgery, they had pretty good level of memory for those words. If we played the words during really a very small dose of propofol, these were people who could still talk to us coherently, there was absolutely no memory for the words. And this is one of Ian's studies, one of the ones that he showed you during his talk. Just shows you people can respond on the isolated forearm technique, even respond conditionally to say they're in pain, and have no recollection of doing so afterwards. Now, when I'm talking about the volunteer studies, you might be thinking, oh, psychologists, they're just lists of words, you know, who'd want to remember those? People often were talking to us quite a lot during this process. In a subsequent study with propofol, it took us quite a while to get each individual's dose of propofol titrated to the right level of cognitive impairment. And because they were anaesthetists, they were often calculating what the total dose of propofol they'd received was. So we would tell them, you're getting this amount as an infusion rate, and they'd say, well, how long have I been having that? 12 minutes. Okay, so I've had this amount so far. Shouldn't I be feeling a bit sleepier? And so on. So they were able to do this mental arithmetic. One person, for instance, had bad eczema and sat up while we were doing this, took a little tube of cream out of her pocket and took the very tiny fiddly lid off and squeezed some out, rubbed it onto her fingers, put the lid back on, handed it to us and said, sorry about that, I was really itchy. And then shut her eyes again. Had no recollection of it on recovery. One of the men who took part said, oh, bother, have you started giving me propofol now? Because I forgot to ring my wife and tell her that I'd got the job. He had no recollection of telling us that, giving us the message. And we said afterwards, you asked us to remind you about something important you had to do. I said, did I? Can you remember what it was? So it's not just our experimental words that people struggle to remember, it's real life important things as well. So I then moved on to the question of, if people are that awake, you know, that they're still able to talk to us, still quite mentally competent, but they're receiving some sedative doses of anaesthetic, do those experiences leave any trace in memory at all? Even if people can't recall them, sort of bring them to mind at will. So this is where we were studying implicit memory, this idea that some experience, for instance, hearing a word, can have an impact on your subsequent behaviour without you remembering that you heard that word. And I'll give you one of the earlier examples that we played about with. The false fame effect is where you play people some made-up names. Like Sally Baker, I hope, isn't the name of a famous person, not somebody I've heard of anyway. I was doing this on the train and I couldn't Google her. So you hear these words, and then at some point later, you're given a list of a mix of those names, some other made-up names, and some genuinely famous names, and you have to pick out the famous ones. And you know that if you heard them before, they can't be famous. And what you find is that people make the false fame effect, so they might say that name they heard before was famous when it wasn't. And they're more likely to do that if they've heard the name before, because they get this sense of familiarity that you then attribute So it must be because that person's famous. I've heard of them before. And one of the really interesting things, and there was a huge amount of excitement about this at the time I was getting interested in anaesthesia, was the finding that people with organic amnesia, so they'd had damage to hippocampal areas or temporal lobes, lost the ability to form explicit memories. They still showed all these implicit memory findings, so they would still show the false fame effect. And this opened up sort of a whole new area of how could we tap into this, this remaining memory function to teach people things that would be useful to their rehabilitation after brain injury. So it seemed an obvious next step. What about people who are having anaesthetics? Now, there's two graphs here. These are from the study with propofol. We tested people without propofol. Then we tested them again with what we called a light sedation with propofol, which was a different dose of propofol for each person. We kept increasing the infusion rate until they made a set number of mistakes on within this recognition test. So this is a test where people hear a list of words and they have to respond if this is the second time they've heard a word. So they might hear cat, dog, cat, and they raise their thumb the second time they hear cat. And there's different gaps between the words. So this graph shows you performance on that. So when people receive no propofol, they're getting they're missing a few of the repeats as the delays get longer and it gets harder. When they've got the smaller dose of propofol, they're getting them nearly all right if they're repeated immediately, so cat, cat, or after one or two, it's cat, dog, horse, cat. And then they're getting a bit worse as they get harder. But that's a pretty good level of performance on quite a demanding test. And this is the deep sedation. People are still able to raise their right thumb in response to command, to detect a few of the words that are repeated very quickly, but nothing else. Even at this point, where they're really doing pretty well on that memory test during sedation, they've got no recognition of the words afterwards, and they're showing no false fame effect. So no explicit or implicit memory. So that made me think, what about all these studies that are appearing in the literature claiming that not only are there these little bits of memory priming during anaesthesia, but that people can learn the answers to trivial pursuit questions, all sorts of facts, all sorts of demonstrations, apparently, that there was some memory function continuing during anaesthesia. And because I was working with Gareth Jones, who is Professor of Anaesthesia, very interested in EEG monitoring of depth of anaesthesia, I had my suspicions that maybe patients just weren't properly anaesthetised in these studies. But there were all these studies saying, yes, we have evidence, we play patients information during surgery and they remember it afterwards. And there was a similar number of studies saying, no, they don't. So that got me curious. It didn't seem obviously to be the case that the better studies showed no evidence of learning, the ones where patients were less likely to have been awake. But to be honest, most of them were pretty poor. And that is one of the things that has really changed in the field, just sort of the quality of a lot of the research. So we went back to basics. And I say we, this was largely Catherine Deeprose and myself. And we said, let's look at the very simplest form of implicit memory, perceptual priming. So this is simply looking at the fact that if I say a word to you like tractor, that will, for a little while, increase the extent to which that word is activated in your existing memory. So it's not a new word, it's not some new information you've got to take on board, it's just messing about with stuff you already know. And we can test this sort of memory by, for instance, playing the word tractor, and then saying, tell me the first thing that comes to mind when you hear tra. And we'll make sure that normally you might say track or tramp, but if you've heard the word tractor and you have some implicit memory for it, you'll be biased towards saying tractor, compared with somebody who hasn't recently been played that word. Now, we wanted to make absolutely sure we'd given it our best shot, so we assessed a whole range of implicit memory tests for sensitivity, their ability to pick up tiny amounts of memory. We checked that they weren't contaminated by explicit memory, so people thinking back and thinking, oh, I bet it was one of the words that I can remember hearing. We made sure there were no ceiling effects. We used software to get our word stems so that they were exactly the starts of the words that we had actually spoken to patients on our recordings. We randomized word presentation order. We did everything we could to give it a good shot. And I was sure this would show once and for all that there was no memory for information presented to patients during anaesthesia. So this is the first time we did the study. Standardised anaesthetic, everybody received the same sort of anaesthetic. Half the sample received the words just before surgery started and half just after the start of surgery, so we could look at the effects of stimulation. And we measured bispectral index as a proxy for measuring for depth of anaesthesia. I really wish we had done what Ian and Michael had been saying, which was to use the isolated forearm technique as well as bispectral index, and then we would really have known. But at the time, and I think this is just a cultural thing, at the time we felt it would be really hard to get a paper published unless we'd used BIS, because everybody was using bispectral index, and because we were psychologists, we would be held to an even higher standard than anaesthetists who were presenting papers. So that's what we did. According to the then manufacturers of bispectral index, our patients were all adequately anaesthetised. The patients who had played the words after the start of surgery did show implicit memory. And unfortunately for Catherine, she was my PhD student, and I was convinced there was really no effect here, so I asked her to run the study again, and we still got implicit memory for the words played during surgery. And this time we looked at bispectral index for every individual word we'd played to make sure there weren't any moments where patients were a bit light, and there was still some memory. Does it matter? Patients didn't know they were remembering anything. I don't know if it matters, but it's theoretically possible. There's a lot of literature in psychology showing effects on behaviour of either sort of surreptitious priming or subliminal primings, priming without awareness of words. So if you're doing a test and there happen to be lots of words associated with being older, then you're likely to walk away from the experiment more slowly than if you've had neutral words, even though you haven't noticed that any of the words were to do with old age. We can make people like foods and drinks more, to consume more of them, to do IQ tests better, and so on. So these are much more dramatic effects on behaviour than simply doing a bit differently on a memory test. So it might matter, and it might matter especially if what is being primed is some underlying fear or anxiety. You know, imagine that you're somebody with spider phobia and somebody plays the word spider to you throughout your operation. That might increase your levels of anxiety more than if they played the word table. We don't know. Ethics committees aren't very keen on that sort of research, so we've never done the study. So, in terms of memory for events during an adequate general anaesthetic, there is no voluntary explicit recall. There seems to be some implicit memory. I would qualify that by saying I don't think there's any evidence that if you get to the lower end of the BIS range, say 50 and below, that you would still get some implicit memory. But I think there's a window where you're unlikely to get any evidence of consciousness, but you can still detect small amounts of memory. Now, what about memory for episodes of consciousness during surgery with a general anaesthetic, or without if it hasn't been connected properly? Well, we know that sometimes there's voluntary explicit recall, and that is what was defined as ARGA, accidental awareness during general anaesthesia in NAP5. That is only when patients tell us that they remember being aware. But there's also more interesting in terms of psychological impact, involuntary explicit recall, where you might find memories of the trauma coming back unbidden. So you've already seen the front cover of the NAP5 report. These are some examples of neutral reports where there was no distress, the patient was aware of what was going on, but felt reassured or interested. It had no long-lasting impact. In a little over half of the cases, there was distress. This, as Jaideep said, was very largely in cases where there was pain or particularly paralysis, but it wasn't restricted to that. So these people reported distress even though they were only aware of hearing voices or other sounds or of sensations being touched or moved but without pain. The important thing is that distress during awareness was very, very strongly associated with long-lasting psychological harm. So all these grey ones, the people who reported distress at the time and had moderate to severe harm afterwards. Now, the reason distress at the time is important is it affects the way that memories are encoded. And this figure is based on some of Chris Bruin's work. And the sort of short answer is that normally when we remember something, it is gradually stripped from its sensory detail and encoded in memory in a more sort of quasi-verbal form that is easy to get hold of and retrieve at will. So, you know, your memory of where you went on holiday last year would be of that type. You can call up the sensory detail, but it is not so vivid and lifelike that you're at the mercy of your environment. So, you know, if something bad happened that involved, say, an assailant wearing blue clothes, if you had a traumatic reaction, you might walk into this lecture theatre, and the fact that there's a lot of blue there might bring the memory flooding back in a way that you couldn't control. Normal memories aren't like that. These memories are also decontextualized, so when it comes flooding back, you don't have those sort of tags on the memory that tell you that this is a memory and not something that's happening right now. So the memory symptoms of post-traumatic stress disorder are all related to this fact that the memories come back intrusively and they feel like they're happening right now, which you can imagine is terrifying and leads to the other symptoms of post-traumatic stress disorder. So this sort of constant state of anxiety and arousal that you want to avoid that happening. You want to avoid anything cueing that memory. And one of the critical things in determining the level of distress at the time of an event is the perceived threat to self. So this is one example from the literature. If a patient interprets the fact that they can't breathe spontaneously as meaning that they're going to die, they're going to feel much more distressed than if they just think, this is a normal part of my operation. And Michael has collated a lot of very persuasive evidence on that. So this is an example from NAP5 of severe distress, and again shows the patient assumed that they weren't going to survive. So if you like, is a classic awareness experience. Now, what I feel is one of the most interesting things to come out of NAP5 are some examples, quite few examples, but I think they're all really important, of how that perceived threat can be reduced. And if you can reduce it, then you reduce the likelihood of long-term harm. So this patient was somebody who knew you were supposed to be paralysed. They had a really unpleasant experience, but the fact that they didn't perceive it as a threat meant they didn't go on to have long-lasting harm and weren't worried about the prospect of having another anaesthetic. This patient was somebody who was given a neuromuscular blocker before the anaesthetic instead of after the anaesthetic, and they did experience paralysis. They were afraid they were dying, that they'd had a stroke, and had some flashbacks briefly afterwards. But the anaesthetist realised that they'd made a mistake and said, I know what's going on and I'm going to fix it. And the patient had minimal long-term harm. You would expect somebody who'd had that experience to have more long-lasting harm than this person did. Now, in memory terms, what's really interesting is that you can reverse the damage even after it's happened. It doesn't have to be during. So this is another example where the neuromuscular blocker was given without the anaesthetic, and the anaesthetist questioned the patient afterwards and apologised for what had happened. And again, the patient was okay, as far as we know afterwards. And this last one is my absolute favourite, because this patient went home. They'd been terrified. They thought they were going to die on the operating table, but they went home and told the rest of the family, and everybody else said, yeah, that happened to me too. And they didn't report it until they were due to have a subsequent operation, and said, yeah, all my family have experiences of awareness, so can you make sure you give me enough anaesthetic? So my conclusions are that patients can be aware during general anaesthesia and not have any explicit recall on recovery. I don't think this just applies to patients experiencing dysanaesthesia. I think this applies to people who are having full-blown awareness experiences, but maybe the ones who aren't interpreting it as a threat to themselves, or for one reason or another aren't distressed by it. They can have implicit memory even without awareness. But I think this is really the key interesting message, that the distress increases the likelihood not only of you being able to recall something, but you having the sort of incompletely processed memories that come back intrusively, and those intrusive, highly distressing re-experiencing or flashback type memories are what will lead to the other symptoms of post-traumatic stress disorder and have, you know, maybe years and years of effect on your life. My final point is that reassurance and explanation, either during or immediately after the experience, can go a long way to reducing the risk. And that insight, which isn't mine, that was the NAP5 insight, but I think we all owe a debt of gratitude to Michael for making that really apparent. And certainly from my own perspective, I came into this as an experimental psychologist determined to sort of clean up the field by doing the experiments properly. Michael all the time was saying, pay attention to people's individual experiences. And I think it was only working together with Michael on NAP5 that I realised the importance of that message. So I'm sorry I ignored you for so long. Because I think those few cases of people who kind of survived, were resilient, who didn't have psychological damage despite really horrible experiences. Those patients hold the key to providing safer anaesthetics, even though we can't prevent all accidents. We can't prevent everybody. We can't make anaesthetics safe for absolutely every patient, but we can stop them coming to harm if we acknowledge those risks and admit them and apologise at the time the accidents happen. So that's all I've got to say. Thank you.